Right. Thank you, everyone. Thanks, Naomi, for inviting us. And let's start with this presentation that will be between myself, Karen Clunies-Ross, and Gabriella Watts from North Metropolitan Mental Health Service in Western Australia. Okay, let's start with our acknowledgement of country. We acknowledge the Noongar people of the Whadjuk region and as the traditional owners and custodian of the land on which we work, and pay respect to the elders, both past and present. North Metropolitan Health Service recognize, respect and value Aboriginal culture as well. We walk a new path together. Next. We acknowledge individual and collective contribution of those with living or lived experience of mental health, neurodivergence or other form of diversity, whose insights are valuable in shaping meaningful change. Just a brief disclosure, this presentation is not sponsored. Data presented were collected as a part of a quality improvement project for North Metropolitan Mental Health Service, and clinical opinion provided are representative of the individual presenter and not of the organization we belong. Next. So who we are? I'm Ettore Guaia. I'm a certified child and adolescent psychiatrist and fellow of the Royal Australian College of Psychiatrists, but also I'm the medical co-director of Youth Mental Health and Eating Disorder Service for North Metropolitan Health Service, and I have experience of working with neurodivergent and neurodevelopmental disorder as well in UK and in Italy before to come to Australia. Then we got Karen Clunies-Ross, that is a senior clinical neuropsychologist. She is also working in the Youth and Adult Complex Attention Disorder Service, again at the North Metropolitan Health Service, Mental Health Service. And then we got Gabriella Watts, that is a clinical psychologist, neurodiverse portfolio lead, North Metropolitan Health Service as well, and we've been working together in this for this presentation. Next. Let's first of all have a view what service we are part of the Youth Mental Health Service that actually cover the age from 16 to 24. We provide an acute service that is a youth hospital in the home. There is a basically it's a virtual hospital that offer 14 days of intensive intervention at their home of the young people, 16 to 24, and we also have a youth community assessment and treatment team. Then we have two specialist long-term service that are YouthLink and Youth Access. YouthLink and Youth Access are more tier 4 service. There is no continuing treatment service, unfortunately, and no specialized service for neurodivergent young people. We mostly are providing at the moment assessment only with the Youth and Adult Complex Attention Disorder Service and toward the Gender Pathway Service. So both services are part of the Youth Mental Health Service, and they only offer assessment, but for treatment, we have to refer to the original team where people were referred because they also have a comorbid mental health problem.
So I suppose we're just wanting to start by providing a bit of context to share a bit about the landscape. And I think Natasha and Faye from Headspace have really wonderfully kind of captured the landscape of working in this space of neurodivergence and mental health in Australia. But our presentation is about, similarly sharing the process we've been through in what our observations have been and how we've identified the gaps, and then our recommendations around how we're planning on addressing some of these gaps. So what we've been observing in our youth mental health programs are that young people are often referred in for mental health treatment, and they're referred in with previous diagnoses of mental health conditions such as borderline personality disorder, social anxiety disorder, bipolar disorder, suicidality, depression, amongst others. And clinicians find that young people can have a poor response to evidence-based treatment for these mental health conditions. And at the same time, they're also noticing that these young people are presenting with co-occurring neurodivergent traits. And this can lead clinicians to query whether there might be some underlying neurodivergence in addition to missed or misdiagnoses. So what we see is that this can result in these young people having longer periods of care, there being barriers to discharge because there's inadequate discharge pathways and services in the community for them. We can see a deterioration in their mental health due to poorly addressed needs because their needs aren't being correctly identified. So we can then have an incorrect formulation in terms of understanding what's happening for that young person. We might see disengagement or persistence in the young person's unhelpful coping strategies, and persistence of challenges in kind of day-to-day functioning, because the young person's unable to access appropriate supports in the community. So we also find that our experience has also been that clients with suspected ADHD and autism are the ones that tend to be most commonly presenting in crisis and accessing our higher level youth mental health services the most. So in March 2024, Youth Mental Health established a neurodiversity portfolio. So the aim of the neurodiversity portfolio was to guide the direction and transformation of how the services provide inclusive and neuro-affirming mental health care. The portfolio is essentially a team of clinicians and representatives across the youth mental health services. And we've been really fortunate to currently have representation across disciplines as well. So we've got psychiatry, clinical neuropsychology, clinical psychology, occupational therapy, nursing, social work, and an Aboriginal mental health clinician. And one of the first things we did as a portfolio was to do an internal survey. So we set this up and distributed it to youth mental health clinicians, essentially asking them to provide some information and feedback on clients on their current caseload. And we were looking at things like numbers of diagnosed and suspected neurodevelopmental diagnoses based on DSM-5 criteria, in addition to other information we were looking at, such as if a clinician suspected that a young person potentially had an undiagnosed neurodevelopmental diagnosis, whether they'd been referred for formal assessment, and if not, what the barriers to that were, and rates of screening. And the aim was to try and quantify the need for neurodevelopmental assessment, supports and augmentation of therapy for co-occurring mental health challenges. And the idea was that this would then help with the scope and the focus of the portfolio's work. Similarly, recognising that neurodivergence is quite a broad umbrella, and we needed to figure out a way of focusing our time and our resources in a way that would kind of best meet the need of clinicians and clients. So we were able to get a sample of 125 young people, and amongst that sample, we found that there was 37% had an existing neurodevelopmental diagnosis. The most common was ADHD, autism, and then specific learning difficulties, so dyslexia, dyscalculia, and dysgraphia. And that made sense because it was quite consistent with what we were seeing anecdotally. And then 54% had a suspected neurodevelopmental diagnosis that was requiring formal assessment.
So in addition to the survey of the clients in youth mental health services, our youth and adult complex attentional disorders service underwent a service review as well, which also involved stakeholder consultation and direct interviews with our stakeholders as well, and integrating the information from the survey that Gabby just spoke about and the YACADS review. Two of the key areas that were, I guess, impacting diagnosis and assessment and treatment were lack of access to timely assessment and diagnosis of either autism or ADHD for our young people, pardon the hypo there. And some of the factors contributing to that were a lack of standardized screening processes within our mental health services. So young people not being identified early on in their engagement with youth mental health. Other factors were low staff confidence and competence in understanding what neurodevelopmental differences might look like, especially in populations, in our population that is often high masking and has been missed by multiple different services. And also, obviously, a lack of publicly funded assessment services. We have a lot of publicly funded services for children and adolescents, but as soon as you're kind of above the age of 16, it's really hard to get publicly funded assessment for autism or ADHD, and the cost of private assessments, particularly for the cohort that we're talking about, are highly prohibitive. The second issue is low staff competence and confidence when providing neuro-affirming mental health care for neurodivergent young people. So a lot of the stakeholders that we spoke to talked about a lack of basic training at the university level, but then also on the job, very limited access to any sort of in-house upskilling and knowledge around adapting therapeutic interventions for neurodivergent clients. Which then brings us to 3 recommendations that we kind of put together based on the outcomes of those reviews. And I'll let Gabby talk about this one.
Yeah, so one of the recommendations is to offer secondary consultation to case managers. So we're in the process of upskilling our neurodiversity portfolio team to be able to provide this secondary consultation regarding the provision of neuro-affirming mental health care for neurodivergent clients with complex support needs. So what this looks like in practice is that case managers would refer in and then meet with one or more members of the neurodiversity portfolio for consultation or advice around topics that may include things like screening or differential diagnosis, assessment pathways for that particular individual, thinking about the formulation of what might be going on for them, identifying appropriate supports, and mental health treatment planning. And there is the added long-term goal of having secondary consultation in place, which is that over time it will hopefully increase staff confidence and competence in supporting neurodivergent young people, and also fits quite nicely with our recommendation number 2.
So obviously, as I mentioned before, the issue with basic training and training on the job is something that we really wanted to try and address as the Headspace team are within their services. So we're looking at developing a program of training and education for our youth mental health services, covering the most common neurodevelopmental diagnoses that were identified in our survey. So initially kind of focusing on autism, ADHD, and helping our youth mental health clinicians understand things like the etiology, the presentation, how it can look and be masked in different mental health conditions, so that they're better able to identify it and then also work with these clients. We'll also be developing some training around neuro-affirming mental health care. We've recently been very fortunate to have Naomi come and present to our youth mental health services as well. So we're also looking at collaborating with external services that already provide fantastic neuro-affirming mental health care trainings. Because obviously, why reinvent the wheel? The program that we're going to be putting together will be co-designed with lived experience representatives, and will be kind of rolled out in conjunction with our monthly neurodiversity portfolio newsletter, which aims at providing little bits of psychoeducation, information about external training opportunities and different service initiatives to help keep the youth mental health services up to date with what's going on in the neurodevelopmental, neurodivergent kind of space.
Great. And then our third recommendation is around providing autism and ADHD assessments. So I suppose this one is our attempt to address the assessment and diagnosis gap. So we've mentioned previously that there can be a lot of barriers to young people being able to access external assessments. Usually the barriers are related to financial barriers and also difficulty accessing kind of an appropriate assessment service. So what we have done is set up a multidisciplinary team consisting of clinical psychologists, clinical neuropsychology and psychiatry. We also have access to occupational therapy as needed. And we're using existing resources to provide a limited number of autism and ADHD assessments to existing clients of our specialised long-term services. So the rationale, I suppose, for providing it or offering it only to the longer term services are because a lot of the young people we see are very complex, not just complex in terms of their kind of presentation, but also we found that there can be fluctuations in mental health and their psychosocial circumstances that can impact their engagement with the assessment. There can also be sometimes extensive documentation review needed because the young people don't have collateral or developmental informant. And then also we need to take into consideration the time frame needed for this whole assessment process and needing to ensure that the client's receiving case management for the duration of the assessment so that the case manager can support their engagement and also to help manage any risk issues that might arise and also to help with follow-up and implementation of some of the recommendations at the end of the assessment.
So just to make a conclusion, so definitely we are looking to have an integrating a neuro-affirming mental health care approach for neurodivergent young people that definitely will require neuro-affirming champion to lead and affect change, systematic identification of gaps in our care for neurodivergent young people, and again, target service planning to address gaps at local and state level. In my opinion, that's what we've been considering is that it should be part of everyday business in mental health and having a comprehensive approach to understand the neurodiversity and embed standardized practice and access. So it's basically, we feel that having specialized service, it's important, but more important is to make sure that appropriate treatment is offered while they are accessing mental health care and need to be taken into consideration. That's all from us.
Thanks everyone for listening.